Hi everyone, it's Derek here from AduMed. Welcome to this video based on amenorrhea. Now let's first of all start off by looking at the difference between primary and secondary amenorrhea. In primary amenorrhea, you have the absence of periods in patients at the age of 15 or over who have normal growth and normal secondary sexual characteristics. Whereas in secondary amenorrhea, you have the absence of periods in patients that previously had a normal cycle and normal periods. Also, you've got physiological amenorrhea, which occurs in pregnancy, lactation, and in menopause. So in today's video, we'll take a bit of a look into investigating this condition. With all that said, let's dive straight in. You've got many causes of amenorrhea, but the most common causes are pregnancy, are hypothalamic causes, so these are usually due to exercise, stress, and weight loss. We've also got hyperprolactinemia, which can be seen in pituitary disease and certain medications such as phenothiazine, promazine, and metoclopramide. Our conditions like PCOS and premature ovarian insufficiency are also common causes, and of course our anatomical causes including cervical stenosis and intrauterine adhesions, which you can see in Asherman syndrome. We can arrange some tests in primary care to further investigate the cause of amenorrhea. Now, a pelvic ultrasound scan can be useful to assess whether uterus is present or not in primary amenorrhea, or if PCOS is suspected. We've also got our blood tests, including a prolactin, TFTs, FSH, LH, total testosterone, if there are clinical features of androgen excess. So let's take a look at prolactin. If we arrange this test and we get levels are over 1,000, we need to refer the patient to endocrinology to carry out certain imaging such as an MRI scan. Possible cause of prolactin being raised at this level include a possible pituitary adenoma. Now, if the prolactin is mildly raised at between 500 and 1,000, this is most commonly due to medications such as metoclopramide, phenothiazines, and domperidone. We therefore need to repeat this before considering a referral. Now, before moving on and looking at some of our hormonal tests that can be arranged, I think it's important to understand the hypothalamic pituitary ovarian axis. This is a complex system in the female body that regulates the menstrual cycle and fertility. The hypothalamus releases gonadotropin releasing hormone, which stimulates the pituitary gland to produce FSH and LH. These hormones then stimulate the ovaries to produce estrogen and progesterone, which then regulates the menstrual cycle. In turn, the levels of estrogen and progesterone feed back to the hypothalamus and pituitary, helping to regulate the production and release of gonadotropin releasing hormone, FSH and LH. So this creates a really dynamic integrated system that helps to maintain the reproductive function in women. FSH and LH are really useful tests to help us tell the difference between ovarian causes of amenorrhea apart from hypothalamic causes. So a high FSH and LH occurs with premature ovarian insufficiency. Low FSH and LH levels usually indicate a hypothalamic cause. It can mean there is constitutional delay, anorexia, or in short patients an intracranial lesion. Now, a normal FSH with normal or slightly increased LH may indicate PCOS. Thank you so much for watching today's video. As always, if you found it helpful, don't forget to leave a like and subscribe. I've also attached a link to our women's health playlist in order to help you to build up a bit more knowledge and skill within this topic area. Until the next time, I'll see you soon.